while Dr. Kaler gets that presentation pulled up, I'm going to introduce myself and the rest of the Families and Health Special Interest Group leadership team. And we're going to give a brief introduction about why the presentation today, the topic of the presentation, is relevant, particularly at this time during COVID-19, as well as relevant to the Families and Health Special Interest Group. So I am Dr. Ruth Nutting. I am Chair-elect of Families and Health Special Interest Group. Dr. Stephanie Trudeau has been our amazing leader this year, and she's currently on maternity leave, so I'm filling in for her. On the call today, we also have Dr. Max Tedeschi. He is our previous chair. And then our current secretary is Dr. Allison Wong, and our early career representative is Dr. Jessica Goodman. So Max and I were going to take a couple minutes to talk about today's presentation topic and why it is so pertinent. So Max, do you want to take us away and give us a few of your thoughts on this topic?
Sure. Thanks so much, Ruth. Thank you everyone for logging on. Seems like we have a big group today, and I know a lot of people are doing a lot of work telehealth and by Zoom, so this is very relevant, as Ruth said. So I'm Max Tedeschi, the outgoing chair of the Families and Health SIG, and I think this topic that Dr. Kohler and Dr. Fleischman are presenting today is very timely on IPV. As many of you may know, there's around 20,000 calls per day on hotlines around the country around domestic violence and IPV. It's becoming an increasingly problematic topic, especially during stay-at-home across different states. I think this is very timely for the Families and Health SIG because obviously this is not only a family-related issue, but I think for a lot of providers in primary care, and doing a lot of work remotely, as I know Aubrey and Joan will point out a lot, you have to navigate this topic. And I think when we talk and work in systems, we have to think of a larger system we work with beyond just the family and the relationship here. So we're excited to hear what they have to share with this. And I think there's also a lot of undiscovered research and clinical interventions that can be used, even if we're not working in person with couples and families right now and having to do things more remotely as well. So we've been really excited to have this topic and this talk for a while here. So we appreciate both of you taking the time out and have a lot of good insights for us.
Thank you, Max. So to give everyone brief backgrounds on Drs. Kaler and Dr. Fleischman. Dr. Kaler is currently an assistant professor and director of behavioral health at Wake Forest School of Medicine. She's in the residency program there in Winston-Salem, North Carolina. And in addition to training family med residents in behavioral health and integrated care, she leads a team of 4 behavioral health providers embedded within the family medicine primary care training clinic. Her research is focused on integrated behavioral health care supervision and training, patient satisfaction with integrated care services, as well as social determinants of health impact on health behaviors. She is a licensed marriage and family therapist who enjoys working with patients, families, care teams, and larger systems. Dr. Joan Fleischman completed her graduate training at Pacific University's School of Professional Psychology and went on to complete a fellowship in primary care psychology at the University of Massachusetts Medical School. She's the behavioral health clinical director of Oregon Health and Science University's Department of Family Medicine and is leading the expansion of behavioral health services across 6 primary care clinics. She's worked closely with other clinical leaders on strategic planning, program development, clinical training, as well as workflow implementation. She has focused her work on practice transformation, population reach, alternative payment methodology, and team-based care. And her own research and clinical expertise include primary care-based medication-assisted treatment for opioid use disorder and trauma-informed care in medical settings. She's also the program coordinator for OHSU Family Medicine at Richmond's MAP program. All right, feel free to take us away, ladies.
Thank you, Ruth. And thanks everyone for joining today. We have, it looks like about 45 minutes. That was a great brief introduction. And we will try to give you some clinical pearls as well as some of our experience in our clinics and with our learners. And I'm going to let Aubrey start us off.
Thanks, Joan. You filled my muted comments there. I wanted to say I was very impressed with Max and Ruth getting us kicked off at exactly the right on time. So thank you both. We have no disclosures today, and our objectives are to talk about the importance of IPV screening in primary care settings, now more than ever, and even in telehealth situations. Demonstrate universal screening education and protocol, and discuss the impact of COVID-19 pandemic and considerations for telehealth screening. Joan and I are not going to take too much time with definitions and prevalence. We want to make sure we leave time to really discuss the screening, the universal screening protocol, and how this translates into telehealth. But I do want to recap a little bit just to make sure we're all on the same page about what intimate partner violence, or IPV, is. This encompasses physical violence, sexual violence, stalking, as well as psychological aggression, which includes coercive acts, verbal abuse, and emotional abuse. And this can be by a current or former, intimate partner. I think it's so important to take a moment here to really look at how broad this definition is and how reductive we, at least historically, have been in our understandings of IPV and domestic violence, or DV, as physical only, and as something that can be witnessed or observed and then has some sort of physical mark. So all of these below the physical violence are often not leaving marks and maybe invisible to a bystander, but no less destructive.
And I just want to add to that I think very prevalent. Psychological aggression is very prevalent. I don't have necessarily statistics in that, but it's very insidious, and it's often something people have experienced in their family of origin. And so when they're starting romantic relationships or find themselves in a partnership, they it feels normal. It feels familiar, and they are not necessarily identifying it as abuse or coercion. So
thank you. And that point that can't be brought home enough. So thank you, Joan. An intimate partner is defined as a person with whom one has a close personal relationship, which includes emotional connectedness, frequent contact, often definition of couple, but not necessarily, ongoing physical or sexual contact and familiarity. And again, a reminder that this could be not only current, but also former spouses, boyfriend, girlfriends, dating partners, or sexual partners. This is not limited to heterosexual couples or same-sex couples. This affects both. And it does not require sexual intimacy. So two people can be engaging in a relationship that is couple-like and has that familiarity and closeness and emotional connectedness, but doesn't have sexual intimacy, and it can still have intimate partner violence as a component of that relationship. Do you want to add anything, Joan?
Oh, Aubrey, have you seen any of the episodes of Tiger King?
I have not.
Okay, well, there's some sort of.
I was watching Normal People when you were watching Tiger King.
Well, I just was thinking about the relationships that are kind of showcased there, and how we would define those, and would we think of those as relationships that have some sort of intimate partner violence, maybe not necessarily on the physical violence side, but more on the coercive manipulation side. So I'd be curious what people think about that and mull that over. Well, if they've seen that show and seen some of those, I've only seen a few episodes, but I'd be curious what people think about that. But that's what I was thinking about when you were talking about the definition.
And if anybody else is watching Normal People on Hulu while Joan was watching Tiger King, they could apply the exact same question to that. There are BDSM relationships as well in normal people, which cross certain lines of consent, and really fascinating show.
Yeah, Rebecca says in the chat, yes, 100% coercive relationships in Tiger King. I absolutely agree. Like, we could have just designed this entire presentation
Maybe
on talking about like
follow-up.
dissecting some of the like popular TV shows right now, because I think yeah, anyway, I could go on about that, but I'm very fascinated by some of the relationship dynamics in that show.
And the way, right, the portrayal. I'll have to catch up. We know that the prevalence is extremely high for IPV, estimated 1 in 4 women and 1 in 7 men. Lesser discussed is how IPV also impacts men. And we can likely hypothesize that these numbers are under rather than overestimates, because this is something that people do not often talk about and is often invisible to outsiders.
You know, one of the things that has come up for me when I've been working with men is that there's this threatening around not being able to have contact with their kids. If they were to leave, or if they were to change their behavior in some way, that there's a threat about not having contact with their kids. So I think a lot of times children are used as kind of as part of a threat.
Right.
That is definitely something we can be listening for when we're talking to folks and hearing their stories.
That is a great point. And unfortunately, that threat is also used against women, and maybe not to the same degree, but I'm glad you brought that up, Joan, the way that children in a family picture can be used as part of coercion. And here's a statistic that I think we're referencing, Joan, that the psychological aggression, so nearly half of all women and men in the US have experienced some form of psychological aggression by an intimate partner in their lifetime. And that's where this really broadens, this definition broadens a great deal to half of the population. And that could be name calling, again, using the relationship or threat of taking something away as leverage. It can be manifest in so many ways that are often insidious and, again, quite invisible, and hard for the person who is experiencing them to maybe gauge if this is normal or abnormal, especially if family of origin had some of these traits or patterns as well. And not a one-time thing. So this is a statistic that happens to be about female survivors, but I assume something very similar could be said for male survivors of intimate partner violence, that these survivors have been at 80% level previously victimized by the same offender. So this is episodic, and unfortunately often intensifying over time. So becoming more threatening and potentially more lethal over time. Do you want to add anything, Joan?
Nope.
Okay. We know that we need to be screening in primary care. Institute of Medicine, Department of Health and Human Services, the Preventive Services Task Force, Affordable Care Act, all recommend universal screening of, at a minimum, girls and women. And prevalence rate of IPV screening in primary care, however, is nowhere near the benchmark of all girls and women. It's 1.5 to 12% of patients, depending on which source you consult.
And I would say that that citation that we have is actually 19 years old, and that there may have been some improvement of this, but I put a caveat at that, where there has been a push in some areas of the country to do direct screening, and we're going to talk a little bit about the difference between direct screening and using a universal education approach. And I definitely have some qualms with the direct screening approach. So although that number may have increased over the last 19 years, the question of like how effective the screening that's taking place is a question in my mind.
So who to screen, and I believe I was taking this slide, is that right, Joan? And then you go after. we want to screen adults and adolescents, new patients, annual visits, contraception visits, as health indicators would suggest that this would be applicable. The hope in this slide is to encourage as much screening as possible. You saw in the previous slide that the recommendation is often universal screening for girls and women, but we know that there's also a high rate, 1 in 7, of IPV for men. So in rolling this out, it's advisable to select a visit type or in certain practices, a certain population at which you would start this screening and then roll out more globally. What would you like to add, Joan?
I think these are just ideas of who you could screen or when you could screen. So this is both a combination of populations and like certain visit types or frequencies.
Mm-hmm.
And I think that when you're thinking about, oh my gosh, like really you could screen so many different people in so many different situations, but like thinking about if you're just starting this practice, picking one and getting really good at that, and really training up your providers to feel comfortable with the flow and with the method that you've chosen to screen. But I think providers often feel like they're doing this work by asking questions just as part of their interview, and some of them are very skilled at asking open-ended questions or making some suggestive statements or putting something out there and asking for a reaction. But a lot of people will revert to just some direct screening questions. Do you feel safe at home?
Mm-hmm.
We've learned that actually that's not a very effective way to screen. And Max is reminding us to use the chat box if people have questions or comments. I'll be looking out for those and go ahead and throw them in the chat box, and we'll try to address them at the end if we don't get to them during the presentation.
Okay, I appreciate that reminder. So how to screen. We'll talk in a moment about what this looks like in telehealth. And these are more global for both telehealth as well as face-to-face. Privacy, especially since it's a especially sensitive and potentially risky conversation to be having. So interviewing the patient alone is crucial. And reviewing limits of confidentiality, as well as knowing your own state regulations, which really vary nationally around what needs to be reported in the way of criminal violence or domestic violence. So a statement along the lines of everything here is confidential, which means I won't talk to anyone else about what is said unless you tell me something that requires reporting. And this might include harm to a child, risk to your own life, or serious risk to other lives. That sentiment and those words are often included in new patient consenting paperwork. And we think it's incredibly important to revisit that statement. Even though legally the patient has likely consented, they've signed an umbrella consent for everyone in a practice. Highlighting that again before moving into this sensitive conversation is really important. Joan's turn.
So as any of you came to the presentation at the 2019 conference, Aubrey and I presented on this, and we went into a little more depth on how to use universal education in primary care. I am a huge fan of universal education. I think really it should be the gold standard for screening for anything that brings up stigma or shame. And I think that you can really apply this approach of universal education to a lot of different social and health conditions. So for universal education, the whole idea is that you're not using direct screening questions like, do you feel safe at home? Or has someone hit, kicked, choked, or slapped you in the last year? Or do you feel like your partner and you have a loving relationship? You're not asking direct questions. You're using an educational statement like, this one we've put on the screen. We've started talking to all our patients about safe and healthy relationships because it can have such a large impact on your health. So this is very true. You know, and I think that this is, we know that relationships impact our health in so many different ways. And Futures Without Violence, where we took a lot of this content, we're kind of borrowing and adapting the content. We should definitely give credit to Futures Without Violence, has wonderful training videos that really show how interlinked health and relationships are. So essentially, being able to say something like that, that we know that relationships impact our health, and we're talking about safe and healthy relationships with X, Y, or Z, you know, our prenatal patients, or all of our new patients, or all of our teenage girls. And then this idea of kind of reviewing healthy and unhealthy relationships, and that typically we would be reviewing that on this card that we give folks, and it's this little accordion card. But you could say, you know, a healthy relationship is a place that you feel safe talking to your partner about something that you don't feel good about or disagree. And something that might happen in an unhealthy relationship is that if you were to bring something up with them, they would shut you down and maybe even threaten you with something. And then you can ask a direct follow-up question like, are any of these things happening in your relationships? Or how do you think your relationship is going? Kind of an big open-ended question. Next slide. So, so when we start talking about relationships, I can't read can you move these whatever's in front of whatever that is? Yeah. So when we start talking about relationships with all of our patients, it's about healthy and safe relationships. It's kind of like a magazine quiz. I mean, I kind of made this up, and I kind of adapted some of this language from the Futures Without Violence website. But do you feel respected and cared for or nurtured by your partner? Or I think I kind of like these bigger, broader questions of like, how are things going? How do you feel things are going? So if someone says, you know, things are going well, I feel like, you know, I'm comfortable in my relationship and we haven't really had any of these kind of problems before, I might say, I'm glad nothing like this is going on for you, because so many women are in unhealthy or abusive relationships. And so we're giving this card to all of our moms or all of our teens or all of our new patients, so you know how to help a friend or family. In this COVID situation where we're not actually like in person, I might just say, I'm giving this website, or I'm giving this phone number in your either after visit summary if you're using Epic, or I'm having everyone write this down. Now, you have to think about who's going to have access to this information. So writing something down may not be a safe choice. Putting something in their phone also may not be a safe choice. We might need to put it under an alias, like the DV, like the IPV hotline might need to be put under, like, you know, Snappy's Pizza. You might need to disguise it. But I think that being able to say, you know, I'm talking about this, I'm so glad this isn't happening for you. And we know that it's happening for so many people right now, that hopefully talking about it with you will help a friend or family member in the future. And then the idea with a positive screen is this scripting here. You want to say you're really sorry this is happening. You absolutely want to say something about them not deserving it, or it's not their fault. And then you really need to convey that you're worried about their safety, that you are concerned about their safety. So next slide. So these are some thoughts around telehealth and how to screen on telehealth. Aubrey, do you want to talk a little bit about this?
Sure, and a great question came through that I think I can address really briefly from Lucy about, and I was trying to type a response and that was what was in your way. I apologize, Joan. That you cannot essentially ensure confidentiality between care team members. Lucy asked about what about an OB practice where you have many care providers working together, and I would encourage you all to be also educate your patients on how your practice works. So when you're talking about confidentiality, you're also letting patients know that you work collaboratively as a team with the other healthcare providers in the practice, and that you're ensuring confidentiality on the team who are working with that patient on the patient's care. So that would be my recommendation there. And we can talk more about that as we get closer to the end.
I think that is really tricky. And I think
It is.
that it's a time to use kind of your curiosity skills around asking the patient about what would it mean if the nurse knew about this.
Mm-hmm.
Can we talk that all the way through?
Mm-hmm.
And trying to understand what their fear is, and saying, I also think we document in a shared medical record, and I want to make sure we do talk about documentation because that's really important. But I think that it is tricky, and it's
Mm-hmm.
tricky because we have a shared medical record, and anything that, even if you allude to something in your note, that anyone in the care team could see that. So I think it's really important how we document.
Thank you. With considerations for telehealth, we recommend live over electronic screening and video over the phone. Live versus electronic, because if you are, well, first of all, because we are proponents of the universal screening versus direct screening, and a electronic screening would entail some like hits using a survey or a questionnaire. Also, because if that screening is positive, you're not there to give resources or be responsive or assess for safety. And that creates all kinds of concerns for the patient, and also, of course, liability with your practice. So live over electronic, and also video over phone, again, probably for obvious reasons, but just to expand that a little bit, there's a lot that we miss when we have audio only. And if we can connect to the patient through the visual and the audio, that tends to be a more comfortable environment for both the patient and the provider, but also gives you more information as the provider in terms of body language or in the patient's surroundings, and to confirm that they do appear to be in a private space. Just as a side note, for those of you who are using electronic screening for this or other considerations, there are some challenges specifically with adolescents and proxy accounts, and whether or not their answers are confidential. Of course, parents guardians are entitled to access to an adolescent's health record. But with a proxy account, it can kind of give the illusion to the adolescent that he or she is only responding in a way that the health provider can see, but in fact, maybe the parent can see as well. So it's just an important consideration with electronic screening.
And Aubrey, one of the things that I just have been thinking about while I've been kind of listening to you has been other ways to talk about this with patients. And I think particularly during COVID,
Mm-hmm.
Where we have all been staying at home a lot, not having our regular social contacts in the same ways we have, and perhaps staying in a physical location with someone that the relationship wasn't great before, before having to be in the same place with them all day, and possibly co-parenting all day, all night, 24 hours a day, 7 days a week for 2.5 months, that I think is just normalizing it and saying, like, I know I've even been asking my friends, like, how's it going with your partner? Like, I think saying something like, this being at home with your partner for so much time and having to deal with the stressors that we've all been going through, I can imagine has been really challenging. I'm curious about what maybe particular challenges have come up for you, or what your assessment is of how that relationship is going, but just trying to normalize, you know, I mean, this has been challenging. I mean, I've definitely heard people be like, I don't know how many more days I can be in the house with my kids, you know, or how many, or like, oh my God, I'm just gonna, this is like nuts. So I think normalizing it and then really checking in, like, things happen when you're stuck in the same place. Things happen, dynamics shift, and things can bubble up to the surface that were really unexpected. Like, wow, I didn't know that he really felt that way about my phone usage, or I didn't know that she was going to get jealous when I talked to the neighbors, because that's like never happened before, because we've never talked to our neighbors. So
no, that's a great point. It kind of can shrink our world down when we're only interacting with the same people and closed in by the same four walls all day long for months. Something
and
else
just one note about this, I see you're wearing headphones. I would highly recommend doing if you're having a conversation where you're going to be asking follow-up questions around IPV, that people wear headphones, not necessarily you as the practitioner, but the patient, because that much more ensures privacy a lot more.
I think that's on our next slide, but you got it. So that is, yes, essential. So asking patients where they are located at time of telehealth encounter, and this is, I think, easy to overlook, but if you are working with a patient and you don't know where they are in space, in physical location, you're in quite a bind if you were to get information that led you to believe this patient might be in harm's way, and then either they are not able to or do not disclose their location to you, or you're disconnected in some way. It's also really important to know, because if they're potentially out of state, which has occurred, you think people aren't moving around too much during COVID, but it's so variable. I was just supervising a therapy colleague recently who said that she learned halfway through a therapy visit, that the patient had actually, spur of the moment, gone to the beach, just stayed away. So just being aware for licensure reasons, but also for safety reasons of where the patient is located. If you've met with them multiple times before, you maybe recognize the background, you might not need to ask again. But asking where they're calling from or videoing from today, and confirming that you actually have that updated home address in the EHR. Do you want to add anything to that, Joan, before I go to the next slide?
Nope.
Okay.
And Aubrey, just want to do a time check. We're at 9:45 or 12:45 your time.
Okay.
And I can't remember how many more slides we have, and I definitely want to leave a few minutes for questions.
Great. Encouraging the patient to find a quiet, private space, and using headphones, as we talked about. Letting the patient know you'll be asking. So for example, asking these questions about whether or not they feel they're in a healthy relationship. It often lends to more of a qualitative conversation, but in the event that you are concerned about who may be overhearing, framing your question in a way that the patient can answer yes or no, and just endorse or deny whatever you're stating. And letting them know that they can elect to not answer questions or request that the conversation stop at any time. This is very different from the universal screening. And the reason I added this is if you are not as adept as, for example, Joan is at phrasing this in a way that's both expansive, but also gives the patient the opportunity to answer just in yes or no questions. I wanted to give some ideas about how you might screen. And I know that this starts to lapse into more of the direct screening, but just to give you some footholds, asking about, are there any concerns that you have about, are you fearful about anything with regard to your partner? This second question is similar to the HITS questionnaire, but asking about specific behaviors. Also asking about put downs or anything that's controlling or humiliating, and then asking about anything that's threatening. So if you are having a hard time thinking about how you would ask these universal or have the universal screening conversation in a way that is yes, no. These are just some suggestions about the types of things you might ask about. So this, I think we just have 2 more slides here before we go to the pearls. So I'll just run through those pretty quickly, Joan. If you do have a positive screen, a disclosure that the patient is experiencing IPV, offering a compassionate and supportive response first and foremost before you get to any sort of resources or any sort of, got your provider hat on and ready to try to help fix a problem. Direct statements that reassure, offer support and validation. And we can't state enough how important this is, because the patient may not be ready to jump on the resource bandwagon, but they'll at least know that they can come back and talk more about this if they need to and when they're ready. Thank you for telling me. I'm concerned for you. There are so many people in similar situations. It's not your fault. So anything along those lines is incredibly impactful for somebody who's maybe disclosed this to a health professional for the first time. And then moving to reviewing resources, offering a warm handoff or a referral of some sort to an IPV advocate.
A note, if you do have a community program in your area that does utilize advocates, IPV advocates, like we do here in the state of Oregon, IPV advocates actually don't have a duty to report. So they do not have, they do not need to report if there is some sort of, they can continue to work with someone even when there might be IPV happening in the home and there's kids there. So
great, thank you.
That's one of the differences.
So last slide on some protocol is if you do have a positive screen, after you've offered that compassionate, supportive response and giving some resources, it's important that you assess for the safety of the patient after they get off the call or walk out of the office and go on living their lives. We want to make sure they're safe to leave and do so. Concern about safety in the home and times that things are maybe most risky or unsafe. Escalation of violence, are things getting worse or more dangerous? Threats, we certainly would want to know if there's any threats around weapon use or patient is being their bodily harm is being threatened. And then of course, because we know rates of suicidality and self-harm are higher for people who are experiencing this kind of distress, we want to ask about depression or suicidal ideations and whether or not the individual is at risk for hurting themselves. All right.
Can I just, before we go into just the last few points, just want to talk a little bit about documentation. So it is important that you document both a negative and a positive screen. What I would suggest is if you're working on an Epic platform or another platform that allows for open notes, which is when patients can see the notes you write or they show up in their MyChart or other patient portal, that you actually make these notes that you have conversations about IPV, either turn them into a closed note so that doesn't go into the patient portal or isn't seen by the patient. This is because we don't know actually who can access their portal, and we don't know who might be seeing that. And it's really important to make sure that even just the documentation that you were asking the questions not be seen by the possible perpetrators. So I think this is really important, especially if you get into a positive screen and you start doing some safety planning. It absolutely needs to be a closed note. And I would work with your IT people if that is something that you're not sure how to do or if you have the capability of doing. So should we go into pearls?
I think so.
I just wanted to leave you guys with just a few things. This turned into a longer list than I was like, let's just give them 2 points. But absolutely doing this with the patient on their own. They really, it is actually, you can cause more harm by having someone stay in the room with them. Now, if they are in the visit or on the phone with someone like a supportive person who's there to support them, that's very different. But we actually don't know who their partner, that could be their partner. I don't know. It's usually not like their sister or their friend, it's not their partner, but so they need to be by themselves. And then this idea of offering some universal education, normalizing and trying to destigmatize, and then asking a direct follow-up question. And then with a positive disclosure, really making those validating statements and offering support. And I would say, if you don't know what you would, I think we're all afraid that we're going to get a positive disclosure that something and not know how to help. Safety planning, I think, should be in our wheelhouse in terms of kind of the first few steps of safety planning and then doing the safety assessment. But I think knowing your resources, knowing who you can call to take the next step, and how to get in touch with those people. And maybe it's the national hotline. Maybe it's the national hotline, and you guys can call together in the room. And then making sure that documenting those referrals, putting it in the private part of the medical record. I kind of mentioned that. And then
so there was a question about if the patient specifically requests that you do not document, how you would manage that.
Yeah, I think having a conversation about what, like often I'll turn my screen towards the patient and say, let's figure out a way to write this that we both feel good about. One, because this is truly, we know that this can truly affect your health. But I think exploring their feelings around that. Like they're probably feeling pretty vulnerable. They're probably experiencing some shame. They might be really scared. And so I'm trying to understand why that's important. I would make a general statement in their chart that says something like, we had a conversation about how healthy relationships and how relationships affect our health, and asking, would you be comfortable with that statement? And trying to have that conversation.
Okay,
Would you do something different?
No, I think that's, we cannot anticipate everything a patient might ask us about. So giving the caveat about confidentiality, we could have the longest informed consent, verbal informed consent, if we also added something along the lines of we do need to document the conversation that we have today. So I don't anticipate that I would give any sort of upfront disclosure. I think managing it on the back end, like you're explaining, makes more sense.
Yeah. The other thing that we haven't said yet is, and then it's one of my soapbox, is that a lot of behaviors that are abusive and are abuse, people necessarily aren't labeling as abuse or haven't identified that as abuse. So I think when you're hearing someone's story and they're telling you things that are either psychological aggression or threats, and the patient hasn't identified that as abuse, it is important for us to actually make that statement.
Mm-hmm.
Wow, that sounds extremely scary. What you're describing to me sounds like abuse. That kind of behavior sounds like abuse, or that is abuse, or that sounds violent. That's violence. That's harmful.
Mm-hmm.
And I think then people are like, oh, it's not that bad, or it's been going on forever, or he's always been like that, or whatever it is that comes up, and say, yeah, you have figured out how to cope with this or live with this, or you're very resilient, or whatever you would say, like, yeah. And when you tell me about whatever XYZ, I'm scared for you. Like, I think we can't underestimate our concern, underplay our concern, and also labeling things, because people aren't labeling it themselves often. So I'll stop talking. Yes, it can start to feel normal, Jen. Yes, or it always has been normal, or that's how you grew up. I mean, I think that a lot of this is that, I've been thinking a lot about, where I did my fellowship and where Dr. Lucy Candid practiced is a refugee resettlement site, and we have just expansive cultural differences, lots of different people from all over the world, from different cultures. And I think we also have to have a cultural lens, and we didn't really talk about that here today, but I think that's very important, of having some sort of a cultural lens and saying, how does this fit into this culture? What's normative for the culture? What's normative to my culture? Is there a gap here? And not villainizing something that's normative in a culture, but also recognizing when something turns into abuse. So
really good question coming through about when do we have to notify law enforcement. And I believe that Joan did a good job of highlighting that it's very different state to state. Some states have mandated DV or IPV reporting, and others do not. The majority do not have mandated DV or IPV reporting. So rather it's criminal violence reporting, which involves what type of weapon was used and with what intent. So you'd need to look up your state statutes. Yes, Jen is chiming in, weapons, children. So in the event, for example, that a sharp object or a firearm is used, there's usually, and again, check with your state, mandatory reporting there to law enforcement. And then if children are witness to that violence, which the way that is defined can vary state to state, whether it's eyewitness or it can be if it's audible by the child, and the domestic violence is within earshot and not just line of sight, that would need to be reported if there are minors in the home. It gets very difficult and gray in many cases, because the patient may be saying, well, this isn't, there was no criminal intent here to actually hurt me, it was an accident. And you don't want to put the patient in danger by reporting something when he or she doesn't have refuge. So it's a very difficult ethical line where we are mandated reporters, and there are areas which are more or less black and white in the statutes. And then also we have to take the patient's word for the way they're interpreting what's going on right now. Do you want to add anything to that, Joan? It's kind of a half answer that I gave.
I think you need to know your state's laws. You need to know the statutes in your state. And what I would say here in the state of Oregon, if essentially there's blunt trauma with a weapon, then, if there's a broken bone, for example, then that's a reportable assault.
Right.
And the state doesn't really care if it's an intimate partner thing. It's an assault. It was a crime. An assault is a crime. And then the other thing I was going to say is we can connect people with the victim advocate, or like the victim, I'm forgetting, witness program, but it's mainly like the victim advocates through the judicial system that can help people fill out no contact orders and restraining orders. But typically there has to be, it can't just be a threat. So there has to have something that has happened, but they can at least, start talking about, like, it's important. So that's what I was just going to say, that we can help them with no contact and restraining orders. But typically there has to be some sort of event for that, for a judge to put that in place.
Another question about Futures Without Violence universal education links for videos on how to do this. Joan, is that something you can maybe send
to? You can just Google Futures Without Violence. They're based out of San Francisco. They have amazing, the cards are amazing. Their posters are amazing for your exam rooms or for your clinic. However, all the training videos I don't think are like publicly available. They're part of the training. So I would certainly reach out to them. Maybe you could have them come out and do a training. They may be doing some like online trainings with the pandemic. I'm not sure. They are fantastic trainers, and their materials are super quality. I just don't think that you can see if they're online or on YouTube.
I think you're right, Joan. I think we may have stated this, but the cards, if and when you have occasion in clinic to be using those again, are free except for the shipping fee. $10. So you can $10 shipping fee. So you can go online and order. I believe it's up to 500 at a time. maybe it's $250. I can't remember. You can order quite a few in bulk for $10 shipping fee.
Futures Without Violence is the name of the organization. Maybe someone can type it into the chat.
There was also a question about Adolescent Girls, if that was referring to age 13 or age 12. I wasn't able to pull it up quickly on the U.S. Preventive Task Force site, but I'm assuming 12. But that I haven't validated that.
So I know we're at time. It's 1:02. I don't know if our hosts want to say anything, Max or Ruth or Jackie.
Absolutely. Thank you both so much for this presentation today. It is incredibly timely and informative, and I just want to thank you as well as the audience for being patient with some of our delays earlier. I do want everyone to know that I will be sending out on the Save the J listserv this presentation, as well as the Telehealth COVID-19 resource that Aubrey and Joan mentioned regarding confidentiality and universal education, as well as support. So going over really the framework for screening and intervention. Are there any final questions before we let our presenters go? Okay. Well, thank you both again. This was excellent. Do you have anything else to add, Max?
No, thank you very much. This was wonderful. And again, I think we'll be posting this for people who missed it. And just for the audience, thank you, and stay tuned for future webinars as well through Families and Health.
And Dr. Kaler and I are both on the listserv. You feel free to reach out to us individually. We'd be happy to connect and speak to you directly about your practice, about your clinic, whatever you have questions about.
Thanks, everybody.
Thank you. This was great.
Bye.
All right, and I'm closing out. Ruth?